Hello.
Hello. Hi, everyone on the webinar, and welcome, Macarius. My name is Deb Singer, and I am a program coordinator here at TDAI. Welcome to the TDAI Speaker Series. I have a couple of Zoom housekeeping reminders for everyone before we get started. All audience mics and cameras are muted. The session is being recorded, which you've probably seen by now. Chat messages are only viewable to the panelists. If you have any questions for today's speakers, please put them in the Q&A box. It's not anonymous. You can comment on any of the questions and upvote questions there. We'll be monitoring that and feeding that into the Q&A after each speaker is finished. Okay, that's it for housekeeping. And now I'd like to pass it over to TDAI Speaker Series Faculty Committee member, Subhadeep Paul, to introduce our first speaker of the day.
Well, thanks, Dave, and welcome everyone again to this second seminar of the TDAI Speaker Series. This is also the inaugural seminar for our thematic internal speaker series. So today's session will offer an in-depth look at the challenges of measuring and addressing racial and ethnic disparities in public health practice, specifically in medication adherence and community public health programs. So we have two speakers today. The first speaker is Professor Macarius Donneyong, who is a TDAI Core Faculty and Assistant Professor of Pharmacy Practice and Science at the College of Pharmacy. He is also affiliated with the Division of Health Services Management and Policy at the College of Public Health. Professor Donneyong's presentation will demonstrate how to operationalize a multi-level health disparities framework to measure racial and ethnic disparities in medication adherence. So over to you, Macarius.
All right. Thank you so much for the very kind introduction, Subhadeep. Let me first make sure that my camera is on now. Okay, there it is. And
yes, I can
Subhadeep,
see you.
Can you confirm that my screen is showing?
It's yes.
Okay, great. All right, so I'll turn it into presentation mode. Okay. Well, thank you so much for attending this first seminar series. As Subhadeep mentioned, I am giving this presentation together with Dr. Ayaz, who would join later. I think he's teaching right now. So I will take the first part of this hour to give a presentation on some of the challenges and opportunities that we are encountering with respect to pursuing research in the field of pharmacoepidemiology that addresses racial disparities. And so I will first, my background has already been eloquently introduced by Subhadeep, so I will skip this. The outline for the presentation is just a quick background about what the issues are, and a brief introduction of some of the existing frameworks that have been proposed to guide research in racial disparities in general, and how we are applying that in the field of pharmacoepidemiology. And then use a case example to demonstrate how we can adapt some of these existing frameworks to implement pharmacoepidemiologic analysis, and also then talk briefly about future direction. So to begin with, health disparities is so pervasive. If you take, most health outcomes, we always see there is a disparity, and this has been happening over the past decades. And the conundrum here is that there are interventions that have been developed to improve health outcomes across board. But whenever these interventions happen and we see outcomes, there is still always that disparity. Interventions really never close the gaps. Now, we believe that the reason why some of these gaps persist is that although interventions appear to to be effective, they probably are not tailored towards addressing some of the issues that are prevalent among racial minorities. And so they are not able to bring up minority groups to the same level as they are able to with their white counterparts. But how do we go about identifying some of these factors that are mitigating the improvements in health outcomes that we are seeing? The spread of big data provides an opportunity to do that. Now we have more information beyond the typical survey questions that might be used to ask patients about, or just in general, to ask people about some issues that they're dealing with. Big data helps us dig deeper into knowing more about what potential risk factors could be. And the third point here is that research frameworks have been proposed to advance health disparities research. But to date, when I look at the literature, I don't see very good examples of how these frameworks have been adapted to implement disparities research, especially in the field of pharmacoepidemiology. And the two main frameworks for racial and ethnic disparities research that have been proposed are from the National Academy of Medicine and the National Institute of Minority Health and Disparities. And these are the definitions. I'll read them briefly. So the National Academy of Medicine defines racial or ethnic disparities as racial or ethnic difference in the quality of healthcare that are not due to access-related factors or clinical needs, preferences, and appropriateness of intervention. The National Institute of Minority Health has a slightly different, well, not different, but it defines this in a different way. Quote, health differences on the basis of more health outcomes that adversely affects disadvantaged populations. Now, to let us understand what some of the issues here, the National Institute of Medicine, Minority Health and Disparities Research Framework. This is what they have proposed. And when I look at this, it looks extremely busy. It has two dimensions. One is the domains of influence, which can occur as biological, behavioral, physical, sociocultural, healthcare system to produce disparate health outcomes. Then there is also another dimension, which is about the level of influence. So at what level do these domains occur? So you have these broken down into the individual, interpersonal, community, and societal levels. And if you are lucky to get a data set that contains all these variables, please let me know. I haven't come across a data set that contains these variables to enable me to fully implement this research framework. So where do we go from here? At least there are some things that we can do. If we take the National Academy of Medicine's Health Disparities Framework, we can represent it through this figure that I adapted. Now, if you take that difference or gap for any health outcome, so in this case, I'm taking adherence to antidepressant medication. And what we know from the literature is that adherence to antidepressant medications is lower among minorities, especially Blacks, compared to whites. So that difference, the goal is to identify the factors that drive this gap between Blacks and non-Blacks. According to the National Academy of of Medicine, if the proportion of this difference that is attributed to healthcare systems, biases, stereotyping, clinical communication, and decision-making, the proportion of the difference explained by these factors is what the National Academy of Medicine refers to as a disparity. In their view, if this difference is accounted for by individual patient preferences, clinical needs, that in itself is not necessarily a disparity in their definition. So it's important to keep that in mind. But one can argue that these patient preferences and needs in themselves can be influenced by racial differences, their individual differences that might influence the patient's needs or preferences. But the National Academy of Medicine doesn't include that. So it's still an open debate. So let's dig deeper into using a case example. So the topic here is racial or ethnic disparities in antidepressant use and adherence among participants of the Medical Expenditure Panel Survey data, which is called MEPS, and I'll describe MEPS. But before we go into that, just a brief background about the clinical condition that we're dealing with here, which is major depressive disorder. It's a top 5 condition, and given the impact of COVID-19, I don't have data, but just based on anecdotal reports, we have heard that the prevalence of depression is increasing. And what we do know is that there are 2 major treatments for depression. One is psychotherapy, so counseling, and the other is pharmacotherapy, which is the use of antidepressants. Mostly there are other medications, but mainly antidepressants. A majority of them are treated with antidepressants. However, about half of patients get to these antidepressant treatments within the first 6 months. And we do know that lack of adherence is associated with adverse outcomes. For instance, is associated with 2 to 8-fold higher risk of relapse or recurrence. And it also increases the risk of all-cause hospitalization and emergency room visits. So the impact of non-adherence very important, and we need to address that. So the Medical Survey Panel began in 1996. This is an open access data set. The sampling represents the US population. So it's a survey, it's a weighted survey design such that whatever results you generate from this panel data, when you apply the survey weights, you are able to generalize the data back to the national population. And the information that is collected is pretty deep, is quite detailed. And they collect data from families and individuals and their medical providers and employers as well. For the purpose of this example, I'm more interested in these 5 main factors. There are others, but these 5, of course, self-reported race, the data on prescription medication use, self-reported health status and medical conditions, health insurance, and healthcare access satisfaction with care. These are the information that I need to try to adapt the framework for health disparities. Brief MEPS is the data is collected in a longitudinal fashion. So for instance, if you take an individual who was contacted by MEPS to be included in the survey, this particular individual was contacted in 2015. And so the first round of survey, several questions within the first quarter of 2015, which overlaps with the other quarters within 2015 of questions, and to reduce respondents' burden, they spread it out across the year. And in round 3, when they go back to visit this individual, information is collected across 2015 and 2016. And then round 4, 2016, round 5, 2016 to complete. Now, what I need to clarify here is that the information that is collected in 2015 is the same information that is repeated in 2016. So you have 2 measurements of the same information. So the race is going to be the same, but things like your medication use status could change from 2015 to 2016. Now, the medication use information is the most critical part for this example, because the accuracy of this information is critical. In MEPS, participants are administered a questionnaire that asks them whether they are currently using prescribed medications, and an affirmative answer would trigger another follow-up question from MEPS staff, which basically asks the consent of participants for MEPS to contact their pharmacy to ascertain the medication use information. Although the initial information about whether you're using a prescribed medication comes from the participant, the rest of the information is actually collected from the pharmacy on the pharmacy claim. So this is very detailed. And that information that is collected by the staff, not directly from patients, but from pharmacies, are the national drug code, prescription refill dates, the quantity dispensed, who the payer is, and the payment amount for the prescribed medication. And so if we take the medical expenditure survey design, we can leverage it to design a longitudinal study. So in this case, we used, just as an example, use the first year, which is 2015, to measure all the potential contributors of racial and ethnic disparities. And then we set aside the second year, which is the follow-up year, to measure adherence to prescribed medication. So if you recall that busy slide from National Institute of Minority Health and Disparities, which I'll go back real quick. Yeah, this is how busy it looks. And I don't have all these levels or domains, but we have several measures that could serve as proxies to some of those factors that were mentioned in the framework. And these are those factors which I group into clinical needs and appropriateness of intervention, patient preference, healthcare systems, the legal and regulatory climate. Then you have biases and stereotyping, and then clinical communication and decision-making. So the outcome here is refill adherence, which is operationally defined based on a measure called medication refill adherence, which is MRA, and mathematically expressed as the sum of days supply with antidepressant divided by a specific window when you a patient would have had a certain amount of medication. So in this case, because MEPS collects data by calendar year periods, the denominator for defining MRA here is 365 days. And so you take 365 days and you look through the information, the records of individual patient to see for each antidepressant that was filled and refilled, what were the days supply? So within 365 days, if the days supply were same for each fill, if there were 30 days supply, mostly they're 30 days supply. So if there are 30 days supply for each fill, we would expect an individual to have filled their medication 12 times, and you take 12 by 30, getting close to 365. And so you would end up with this individual having about 100% refill adherence. But if the person did not fill medication maybe once or twice, then this proportion is going to be less than 100%. And based on literature, the threshold for clinically important adherence is at 80%. So all MRA values that are less than 80% are considered as non-adherent. So the main goals are to quantify racial ethnic differences, and then quantify the racial ethnic disparities, and then to identify the correlates of observed differences and disparities in antidepressant adherence. So we switch gears here. After looking at how to adapt these frameworks, then we also have another challenge. How do we measure racial or ethnic disparities? You can use your traditional regression methods, but that really just gives you an indication of what factors are predictors. But when it comes to developing interventions, you don't know the level of influence of individual variables on the observed gap. And so this method here, the Blinder-Owaka regression decomposition method, which comes from the economics field, was developed to help address some of these differences. It's a counterfactual framework, and it decomposes observed gap or difference. So the racial gap that you see between Black and whites, it decomposes this difference into an explained and unexplained component, and we'll get into that. So mathematically, you can think of, say, W as whites, B as Blacks, and for a particular outcome, in this case, adherence, you can subtract the proportion who are adherent from the proportion of whites who are adherent, and that gives you the gap, right? Now, with that gap, what amount of that gap is explained by factors, and what proportion is unexplained by factors that were not included in the model, because we have some factors, but not all factors. So the first term here explains that gap. The second term captures the gap that is unexplained. So to the results. So using MEPS data, it's a large data set. We started with about 87,000 participants, whittled down to about 4,000 total antidepressant users. Some were prevalent and some were new users. I can go into detail if people have questions. Based on the data, when we calculated MRA, which is medication refill adherence, we observed a gap of 24% points between and whites. And of this 24% gap, 12% was accounted for by healthcare systems, the legal, regulatory climate, biases, stereotyping, clinical communication, and decision-making. So this is the level of disparity that occurs in whites, according to the National Academy of Medicine's definition. So there is a 12% disparity in non-adherence between Blacks and whites. We can do the same for Hispanics. Here, the disparity is about 10%. Now, after measuring the disparity, we've quantified the disparity. Now, what factors drive these disparities? Remember, these are categories of factors. The individual variables are many, which I don't show in this table just to make it easier to read. But the variables for each category were shown in the slide. Excuse me, and I can go back and show that. But to summarize the results, of all the factors that we considered, 1, 2, 3, 4, 5, for this, those variables that were classified under healthcare systems, legal and regulatory climate were the only ones that were to be associated with the racial disparities between Black and whites. And what this means is that if you address or equalize healthcare systems and legal and regulatory climate factors between Black and white populations, that you would reduce the disparity by 26%. It was rather perplexing that between Blacks, sorry, it should be whites, between whites and Hispanics, that this factor wasn't important in terms of statistical significance. Something that we can dig deeper into in the future, but I wasn't sure why. But none of the factors that we included in the model help or were observed to be important as potential targets for intervention for the white-Hispanic differences. But for Black-white differences, your bank is here if you want to develop an intervention that would be responsive to both Blacks and whites and potentially close the gap. So some of the limitations in the current presentation is that, the data on healthcare regulatory factors is minimal in MEPS data set. And we don't also have granular data on culture and other patient preferences. There are also lack of direct measures of stereotyping or bias, and MRA measure may be limited when you account for switching in medications. So in the future, to address some of the limitations we just reviewed, opportunities abound in data linkages. So for instance, I'm currently working with some colleagues here at OSU and other institutions around this data set called the Southern Community Cohort Study, which has been linked to Medicare and Medicaid's data, as well as a data set that some of my colleagues have developed called the Public Health Exposome, which is a large data set of over 30,000 descriptors of the built, natural, social, and policy factors. So these are aggregate level measures at county level, and you can drill it down to zip code level. So it then helps us understand the environments where individual patients are residing in to help address the legal and political climate within which they live in. And the next step too then is to develop methods on how to apply these disparities framework to assess outcomes in treatment effectiveness. Right now we are focusing on adherence, which is an intermediate outcome, but we also need to address treatment effectiveness as a main outcome. So I will end here and take questions. I don't know how we're doing with time, whether I've chopped into Dr.'s time or not.
No, we're doing great in terms of time. So yeah, as Dev mentioned, that if you have any questions, please feel free to type in the Q&A box. If you would rather want to ask your question verbally, then I think you can raise hand and one of us can enable your audio as well, I believe. Or just type in Q&A and we'll read out the question.
Okay. This is the most friendly audience ever.
Yeah, and possibly explain things very well.
Do we know if Ayaz has joined yet? Or...
No.
No, we're
Okay.
still waiting on him.
Okay, yeah, and I know he's teaching a class, so he'll be a few minutes.
Okay, we're gonna wait a few minutes here for Ayaz to arrive.
Okay.
The questions and Q&A is still available. So if anyone thinks of a question, please write it on the Q&A or raise your hand. We can unmute you.
And my email is here too. If someone would like to follow up privately later, that is also very welcome.
All right, everyone. We are waiting for our second speaker to arrive. So we are going to give everyone a little bit of a break. Please hang tight with us. Going to stop Macarius's sharing, and
Okay.
please check with us in a few minutes. Take a bio break if you need to, check your email, and we will start our second half of the speaker series as soon as possible. Thank you.
Looks like Ayaz is here.
Mhm.
Good afternoon, everybody.
Hello.
Hi there.
Okay, so are you ready, Ayaz?
Yes.
Okay, so our second speaker today is Professor Ayaz Hyder, who is a TDAI Core Faculty and Assistant Professor of Environmental Health Sciences at the College of Public Health. Professor Hyder's talk will describe two current projects where they faced challenges in addressing racial and ethnic disparities. Professor Hyder will further review two approaches that they have applied with diverse stakeholders to solve pressing public health challenges at the county and state level in Ohio. So over to you, Ayaz.
Thank you so much. First of all, I apologize for running late today. I was teaching right before this, and we were kind of having a really heavy conversation about hybrid models, and the students were asking some really, really good questions. So it was a little bit hard to get away from them. Let me share my screen and we can get started. Okay. All right. Well, thank you all for the opportunity to speak today. I'm going to be talking about how in my research I address racial ethnic disparities through the work I do around translation data analytics and modeling for public health practice, giving two examples from ongoing work on the reproductive health system, and then some of the COVID-19 surveillance work. So the first thing I want to do is define what translational data analytics looks like. And I think my video is showing now. Is that right?
Yes.
Okay, perfect. So started by starting to define translational data analytics in public health. This is the definition that I've used for a number of years, and really you can read it because you're all looking at the screen probably. But I want to focus on two words here: generate solutions, right? So how do we generate these solutions for these real world problems or use cases, and then stakeholders, right? So in my mind, coming from a public health background, these are the two things I really focus on. The process by which we generate solutions, and then how those the solutions that we come up with, however simple or complicated they are, that can enable stakeholders, right? And so when we think about issues around equity and disparities, they're important to include in the process by which we're generating solutions or trying to understand the problem, and when we are trying to enable stakeholders to use that solution that we've come up with. So it's not something that is thought about when we're translating our research to practice. In my lab, we try to make it part of the conversation from day one when we engage with communities in coming up with solutions, in like, what is the problem, right? And then that will then carry us all the way through. So that's, conceptually how I do this. And for those of you wondering where this definition comes from, it actually comes from the TDAI website, right? So when it was TDA, not TDAI, this is the definition that when I arrived at Ohio State, I was given, and I really embraced it and thought, okay, I really want to do this for public health. And so the examples that you'll see are hopefully me trying to achieve some of those goals. Word of caution, public health can be messy. As you can see, there are a lot of actors, there are a lot of organizations, a lot of groups that are being affected, and no better time than the current pandemic to show you or to illustrate that, what that means, right? So public health, if you saw the governor's address last night, he touched on probably all of these different dots that you're seeing on your screen, and they're all connecting back to public health, right? So it's an interesting time to be in public health. One of the frameworks that I use for doing translation data analytics in public health in my own research, and then I'll get into the examples, is this approach of engagement, modeling, and translation. And what engagement means to me is community-based or participatory approaches for engagement, however you define the word community. Very rarely do I embark on a research project because I read something in a paper or I had that aha moment or something. I often try to start by looking at what are the problems that are being highlighted in the community, or what are the problems that stakeholders who I typically work with, including our local health departments, that they have. So I'm actively engaged in that and always trying to identify the research opportunities that way. And then, we all have our modeling toolbox, right? That we use, and some of the things that I typically use are examples listed here, primarily agent-based models, starting to look into system dynamics, some sentiment analysis methods, and name algorithms, and also a ton of spatial analyses as well. So, then we bring to bear our modeling toolbox. And so the analogy of having a big hammer, like your methods, trying to hit a small nail, which is the problem, goes away, because now I've actually picked up my method based on the problem that I'm trying to solve. And then there's a translation piece that takes time, a lot of effort, and then but then if you do the engagement in the beginning, you'll get to do the translation piece at the end really nicely. And it's a sort of a cycle, because you can do that translation, and then that leads to further engagement opportunities, and then you end up with more modeling and then further translation. And so it can continue in that way. So let me give you an example of engagement in the around the reproductive health in urban settings. Here I'm showing, and I apologize if the text in gray is a little bit hard to hear, but really the main point is, what this is showing you is the number of deaths per 1,000 live births in Ohio for the last 17 years, from 2000 to 2017, among Black, white, and the overall population in Ohio. So these are infant mortality rates by race in Ohio. And what you'll see is that consistently we have had high infant mortality rates. We're not closing any gaps between the Black infant mortality rate and the white infant mortality rate. In fact, these gaps have remained disparate. And just for those of you who don't know what a 15.6 deaths per 1,000 live births means, in Syria, during the civil war, the infant mortality rate in the country was around 14 deaths per 1,000 live births during the civil war. So that's, to put into perspective this number of 15.6 in 2017 that we're seeing among Black babies in Ohio. Okay, so this is the problem that we're trying to solve with this approach that we used, which was community-based system dynamics. And really the way it works is that it combines elements of community-based participatory research with systems thinking. It allows us to capture the experiences and the perspectives of multiple stakeholders, and then we're able to develop a policy simulation model at the end. And the way that we go about that community engagement process is through what's called group model building workshops. So here on your screen, you're seeing some of the outputs of that group model building workshops that we have been holding with our stakeholders, in 2018 and then 2019. The workshops, the purpose, sort of in one word, the purpose of those workshops were really to listen to the community about the problem, create some conceptual models, some explicit models of the reproductive health system in Ohio, validate those conceptual models, and then translate them into something that, into a policy simulation model that they can use to act on. And the equity considerations that we ran into when we were doing this process were things like, who do we engage with? Who do we invite to these group model building workshops from the beginning? Are we missing out on not inviting certain groups because we don't know them, or we have our own academic or our personal biases that are going to affect that? So who is selected to be part of that group model building workshop can really affect the kinds of models that you end up building. And that was one of the considerations. Another consideration was, how do we navigate, even when we have our set of stakeholders, how do we navigate the dynamics between them, right? So one example of that is if when conflict arises about prioritizing sets of policies, do we approach that from an equity perspective, or do we approach that from a cost effectiveness perspective? What do we do? And so we very early on addressed that issue by saying that we're going to use a reproductive justice lens when we are approaching, when we are building these kinds of models. And that framework, getting everybody on the same page, really helped us address a number of these considerations. And what came out of that workshop is what's called a causal loop diagram. And you can't see this, but I'm going to show you where certain factors around equity came up in this model. And you can see them right here with factors such as stress at the neighborhood or maternal individual level, structural racism and interpersonal racism, implicit bias. These are all the factors that clinician bias that our stakeholders told us about, and that we were able to capture within the policy simulation model that we built for them. And the equity considerations here was that we made these connections between stress and racism a central feature of our model, that a lot of that, you see a lot of arrows coming into that maternal stress variable. Well, and also structural racism. It's also because those are really important. Those were really important to our stakeholders. So ultimately what we're able to do is develop these what if policy simulation models, but underlying these policy simulation models are really rich and complex, and we embrace complexity, models that have equity considerations at their core, that are trying to address these disparities at their core in terms of how it was designed. So moving on to another example about modeling and translation, where we conducted, we're still in the thick of it, the pandemic's not going anywhere, about developing, rapidly planning and deploying a surveillance system around COVID-19 for local informed decision-making as a partnership between schools, between schools, local health departments, and academic institutions like Ohio State. So the objectives of this work were really to inform school teachers about emerging trends in COVID-19 cases in their school districts, surrounding districts and the county. Oh, what happened there? Oh, okay. And then the second objective was to inform students and parents about the rationale for decision-making, switching between different learning modalities, right? So this is ongoing work, and it was done very quickly. The community engagement part of this, again, it was a lot of modeling and translation work, but the community engagement was at the front, where we made sure that we had a buy-in from the school district leads and the public health departments, that our role really, and we call this Project CATS, it's really to provide that technical assistance is what we are doing, but then the public health protocols around response and case investigation and contact tracing, that's all done by the school district and the public health lead. So we very clearly got in our lane and identified our lane in this community engagement process, and then we're sticking to it and make sure that we don't go overstep in anything that we're doing in the future. The overall, from a research side of things, well, this was not research, this is a service project, but the question that we were really trying to answer is how can we increase the lead time that our school district partners and public health partners can have for making decisions to close, take action to reduce the probability of outbreaks in schools based on the data that we're collecting. And the data and the analysis part of this was bringing together data from multiple sources into the Ohio Supercomputing Center. So I'm not going to go through the whole thing here, except to say that in this project, we had to deal with very disparate, some of the equity considerations, right? Were in terms of the capacity of local health department, of local school districts, in terms of their ability to provide data. Their systems were different, all of them. They were, some of them were outdated. Some of them required us to do a lot of the cleaning of their data before we could use it, and then train them in even, how to send data over through SFTP, for example. But once we addressed those issues, we were able to bring those data together, process them, analyze them, and then develop these visualizations, alerts, and reports that are now informing decision-making, and that's a translation part, informing decision-making in school districts. These are a couple of the products that we're delivering to our partners. Again, this is the translation part. There are dashboards, the publicly available and securely available dashboards. There are weekly reports that we're generating for school districts. And all of this is allowing them to be very transparent, very forthcoming with their partners about, with their parents and their constituents about how they're making decisions at the school districts. Now, some of the equity considerations that came into this is when we see cases rising within a certain building or within a certain district, what is our recommendations, right? As analysts, what do we recommend to do? Now, the problem with that is each district in Franklin County is very distinct in terms of the gradient of socioeconomic status, the social emotional learning impact on the students. And so we don't have that knowledge for that area. I live in Hilliard. I know Hilliard pretty well. I can understand how to make decisions there, but I don't know much about other school districts. And so we partner with the local district leads to say, you help us make the decision. We're going to provide you with the data broken down by different race, ethnicity, free lunch program, these other considerations, but you are the ones making those decisions, and we're providing you that information. So examples of that translation part is that schools are now using the data that we're providing in this column 2 that you see here and column 3. Those are, and then those thresholds, those are all based on the data that we're providing through CATS. And other examples from Dublin City School District. And so that's all I have for all of you today. And I'm happy to take any questions now.
Okay, thanks, Ayaz. We have one question in the Q&A from Harvey Miller. So the question is, can you speak in more detail about challenges in converging on a conceptual model with a diverse group of stakeholders? This seems almost impossible given that public health issues are often wicked problems.
Yeah, absolutely. So as Casey Hoy has reminded me many times, wicked problems, they don't have solutions, right? That's why they're called wicked problems. So what we can do is try to come up with some types of answers that are not going to solve the problem, but are still going to help us address the issues that they raise. And so to answer Harvey's question, by making, so one way we address these things is by going through in the scripts that we use in group model building workshops is diverging scripts and converging scripts. And what these diverging scripts do is that they are facilitated discussions, activities, hope and fear, connection circle exercises, that's what they're called, that allow us to get a better picture of what are the different things that everybody in the group cares about, and then allow them to vote on and discuss as a group which are the ones to prioritize to solve for, and then converge towards a final version of a conceptual model that we can then use to then further build out and obtain data for and then put into the simulation model. So it really is a multi-stakeholder criterion that's used, but it's done in a way that is done in other fields as well. But then we also create a boundary, like the boundary space in which we're working. Like, we're not going to model the world, but we are going to try to consider what are the most important policies that can address this, that we feel, given our current scientific knowledge and lived experience, that we can address those, which are the policies that are going to be more feasible. And then we help facilitate that and build that into the modeling process.
Okay, are there any other questions from anyone? Once again, a reminder, if you would rather ask a question verbally, we can enable that. We can unmute you. Just let us know.
Hi, Ayaz, it's Harvey again. I want to follow up with my question. So
Sure.
once you build this conceptual model and you have the results of that model, do you then share that with the stakeholders, and what's the process to get them to understand the
Right.
results of this modeling exercise?
Right. Yeah, no, the communication part is very critical. So in the 4 workshops that I showed, we actually have a 5th workshop coming up soon, where we're going to be showing the model that's been developed by Rudy Hightower and his group, who's been working with us, that is documented, that is very clearly laid out. What are the assumptions that are made in the model? What are the data that are used? I mean, we even go down to the level of getting permission from our stakeholders about what types of data we're allowed to use in building that model. So we don't do anything that the group doesn't want us to do. And what that does is that it builds the trust with them to say, okay, we understood, maybe not all the technical details, but we understood how decisions were made, and this model was developed, what data were used to calibrate and validate this model, and what is it that we're getting. Because ultimately we want our stakeholders to use that model in real world settings. And they're not going to, if they don't have confidence in it, right, then why would we expect them to use it in the real world setting? So, this whole idea of all models are wrong, but some are useful, it's true, but then I go a step further and say, but some models are really useless. So how do we identify the useful models, the most useful models? And I think that comes through participatory modeling approaches that take a lot of time and effort, but I think at the end of the day, the payoff is definitely worth it, in my experience.
Hi, thank you. So I've in the meantime typed my questions, but so particularly in the settings like this, where we not only have different priorities, you pointed out that different school districts may have completely different set of parameters for decision makers. We also, there may be also very different sets of priorities and notions of fairness, and also very different set of downstream effects for every set of decisions.
Right.
Just to give an example, that I'm more familiar with the deployment of testing, COVID testing clinics results in our evaluation. and disparities in evaluation of the burden of disease then resource, leads to decisions of resource allocation, which then leads to health outcomes and disparities in health outcomes, and continuing with resource allocation and so on.
Sure.
And so evaluating these deep downstream effects it's very difficult to do it in a sort of model transparent way.
Sure.
And two, particularly as we're increasingly using machine learning approaches to do that, there is a trade-off of model transparency versus model accuracy.
Right.
So how do we present these different possible outcomes to build trust while trading off the transparency versus accuracy?
Right. Absolutely. No, that's a good question. So the way that we've approached this in both of these projects that I described is by recalibrating how we engage with the communities and our stakeholders, and always being mindful of those issues around transparency and how uncertainty will propagate not just from the data that we're using into the model, but also the decisions that are recommended by the model, and then what happens in the real world, right? So keeping track of that, we don't do it formally necessarily, but we always try to do that internally in our team by making sure that we're getting the best data possible. The trade-off, I think, the way we address that issue is by just being very upfront. So in the reproductive health example, we started off by saying, we're using a method that you may not have used in the past, and most of our stakeholders had not, that embraces complexity, that embraces the complex relationships, the feedback loops, the dynamics, the nonlinearities between policies and outcomes and risk factors in the reproductive health system. And so the method that we use are built to address those types of complex challenges. And we even went and actually tried to simplify the complexity in some of our initial versions of causal loop diagrams based on the group's feedback. And that got us into a lot of hot water with them, because they said, nope, we want to embrace the complexity as the frontline staff, as the nurses, as the health commissioners, as the ones making decisions. So give us something that embraces that complexity and is true and will accept the trade-offs, that we are willing to accept the trade-offs, that your data may not be the best. And so we prioritize data that were, direct measures for their specific communities, that were proxy measures for their communities. So it wasn't just data from Ohio, but it was from other places in the US, or parameterized models using expert opinion. And we were very upfront with them that this is what we're using. And we laid out for the 74 factors that were in our causal loop diagram, which ones do we have data for, which ones do we not have, and how that is going to affect the model. So it wasn't necessarily done in like a formal sensitivity or uncertainty or multivariate sensitivity analysis, which we do at the back end, but it was because of the engagement process and how much engagement and how deep the engagement was, we brought them along in the model building process, so that their trust of the model is also commensurate with their trust in us as the ones developing that model. And I think that approach can go whether it's ML, AI, deep learning, whatever approach is. It's just a way of doing modeling that I think is a little bit different than how we've traditionally done modeling in academic settings.
Can I ask a quick follow-up question to that? So the policy simulations that you are doing, how would you validate those in real life? So what would be the validation standard?
Right. So there are Edward Reichel has a paper maybe some decades ago, where he talks about like 20 different types of validation, right? So what does validation mean? And so we can pick certain types of validation that are okay to do with a policy simulation. And when we start off with the purpose of the model is really to be able to not necessarily predict, but explain and help us choose between policies, then the types of validation that we're doing can be adjusted. So face validation is one that we can do with these policy simulation models. Internal validation of the model are things that we can do. External validation as well. Predictive validation, like forecasting or using the model to that was built for one area, but applying it to in another is not something that we would do with these policy simulation models. So there are, once again, there are different types of validation. They always don't have to be quantitative. They can be qualitative types of validation. And the set of validation metrics that you choose need to be in line with what the purpose of that model was. And if the client or the end user wants additional types of validation, we can certainly try to go there, but we also need to be very upfront about the limitations of the model, that, hey, don't use this to plan, don't hold the model to what's exactly going to happen in the next 20 years if you invest in this type of intervention or that kind of intervention in the reproductive health system, because things might change. So I think that is our approach in validation for these kinds of models.
Okay, thank you. So I think that's a wrap for us. Dave, do you have anything to say?
Thank you everyone for joining us today, and please check out tdai.osu.edu for future events.
All right, thank you everyone.
Thank you.
Indeed, I do want to point out that we have another TDAI seminar coming up by Dave Laser. Dev, you want to announce this?
Yes. So next Thursday, we have the Bryce Akery Memorial Lecture with David Laser of Northeastern University. This session is presented in association with the Department of Political Science, and there will be a celebration of Bryce Akery's life and research, a presentation of a posthumous teaching award for him. He passed 1 year ago, and that will be followed by a wonderful presentation by Dr. David Laser. So that's next Thursday, the 19th at noon.
Thank you.
Thanks, everyone. Bye-bye.
Bye.